ज्ञानी जी कहाँ हैं?
You're going to join very soon.
विनय,
Sir, please join. Yes, sir, we will wait. Dr. Gyani will join at 10:15, sir.
Dr. Gyani will join at 10:15.
Yes, yes, sir.
Okay. Dr. Lalu, Dr. Lalu,
Sir, I'm here, sir.
thank
Namaskar,
you.
Dr. Lalu. Namaskar. Welcome.
Thank you, sir. Thank you so much.
Sir,
और
please join.
विनय का बता दो.
He's not well today. He's unable to join today, sir. Okay, sir. No issue. Thank you. Sir, with your permission, should we start now? And rest of our speaker will join later on.
All right. Perfect.
We can start, sir.
Namaskar, I am Amresh Tiwari, editor publisher of Double Helical. This is a monthly health magazine being circulated from Delhi NCR region. It's my kind privilege to organize today's webinar. Topic is patient safety. As you know, patient safety defined as the absence of preventable harm and the reduction of unnecessary risk in healthcare is a critical pillar of modern medicine. I hope this webinar will explore a structured framework to strengthen safety cultures, processes, technologies, and behaviors, ensuring consistent risk reduction and error prevention across healthcare system. For this, today we have the eminent speakers like Dr. Girdhar Gyani. He is going to join very soon. He's a quality man of India, Director General, Association of Healthcare Providers India, and the most respectful Dr. Vijay Agrawal. He is the President, Consortium Healthcare Association KAHO. And we have the Dr. Amitabh Banerjee. He is the well-known public health expert and Professor Emeritus, DY Particle Medical Colleges, and Dr. Lalu Joseph, she is a Quality Manager, Associate General, Superintendent CMC Vellore, and one of the most active members of the KAHO. Now, with this brief introduction, I would like to honor Dr. Arun Agrawal Sahab. He is the Professor of Excellence, and currently he is the advisor clinical research innovation Apollo Group of Hospitals, New Delhi. Sir, now I would like to request to Dr. Agrawal to moderate today's webinar. Thank you, sir.
Thank you. Thank you, Tiwari ji. Good morning to all my friends, colleagues in front of me. And again, my thanks to Double Helical Magazine, which is looked after by our friend, Mr. Tiwari. And this Double Helical Magazine, which is there for last more than 10 years, has really created an impact in creating awareness among medical professionals, among the non-medical part of our society, because all the topics being chosen are perhaps so important that it is useful for everybody. Thank you very much, Tiwari ji, for bringing out this magazine and for this kind invite. Today's topic is patient safety. When I think about patient safety, I always try to think why patient safety. And in my opinion, when we start talking about patient safety, perhaps my colleague, Dr. Vijay Agarwal and other experts will agree with me that we started our medical education in India exactly 190 years back. That was the time when we started having the use of allopathic system in our medical care. And gradually, the science of allopathic system kept on increasing, innovating. We had our first medical college in 1835. And in 190 years, the science has really gone in a big way. The medical education has gone in a big way. And in the entire experience, we realized that there is something which is really useful for the patient, but there is nothing like 100%. There are certain drawbacks, there are certain steps which may not be useful, and perhaps in the practice, there may be some sort of problem for the patient. So that means the concept of patient safety, which was originated earlier, but perhaps in the beginning of 2000, we started talking about it more and more from all angles, and that is why we are discussing it today also. I'd like to start with our friend, Dr. Vijay Agarwal, who needs no introduction, the person who is a very important solid base of the movement of patient safety in our country, and not only in our country, he has already created an impact all over the globe. Dr. Vijay Agarwal, I would like you to comment upon, of course, the concept of patient safety from clinician point of view. But before that, will you tell me what was the need of patient safety?
So, good morning, everyone, and my profuse regards to our friend Dr. Arun Agarwal for moderating this very important session, very close to my heart, and I'm sure close to the heart of everybody who is attending this session here. So, sir, need for patient safety, you asked me before I talk about the role of clinicians. So, first of all, I would say that when we talk about patient safety, it looks as if we are talking about some other people, not us. So we must understand that all of us have been either patients or will be patients, or have been concerned about somebody very close to us as patients. So it is not something that you are talking about a group of people who need help and we are immune. So it is number one for all of us. And second is that this concept of patient safety, although has come to limelight since 1999 from the article by the Institute of Medicine to Err is Human, where they showed that 98,000 Americans were dying because of preventable medical harm. But if you look at it, sir, it started from the father of medicine, Hippocrates, 2,500 years back. And the medical graduates all over the world since then have been taking a Hippocratic oath. And one of the premium part of that oath is that first do no harm. I'm sure he had envisaged harm even at that time. That's why he created that oath. However, that oath has been more like a ritual, and somewhere along the line we have been very much involved into the advances of medical care rather than this accompanying part of the problems which are sometimes associated with it. So I feel that This is something, and it will also become clear as I talk about, in fact, the role of clinicians. If I can share my screen, can we see it?
Yes, sir, not in full screen.
Yeah, I'll just see that.
That's great.
Yeah. So, sir, in this era of remarkable medical advancements, patient safety remains a fragile promise. As I said, that it is been ignored for centuries. And despite the dedication and skill of the healthcare professionals, medical errors continue to occur. Sometimes from momentary oversights, sometimes from communication breakdowns, sometimes from systemic flaws. No individual can fix alone. That's what we have to understand. So I'm just wanting to explore how physicians can lead the way to safer care through effective teamwork. So the modern medical paradox is that on one side, we have these once fatal diseases which are now treatable, advanced technologies which are guiding diagnosis, extended lifespans with quality of life, greater mobility and independence for elderly. Everything is there, but there are preventable errors occurring on a daily basis, communication failures between teams, systemic flaws remaining unaddressed, fragmented care creating safety gaps. So this contradiction defines modern healthcare. Unprecedented clinical advancements alongside persistent safety challenges. The question is not whether we have skilled clinicians, we do, but whether we are organizing their talents effectively to prevent harm. So the hidden cost of medical care is there. It is being, of course, felt by the patients, which will be in the form of physical harm, extended recovery, lost trust in the healthcare system, financial burden, and emotional trauma that can last years beyond the event itself. But we must not forget the impact it will have on clinicians in terms of moral distress, lingering guilt regardless of intent, fear of litigation, professional scrutiny, second victim syndrome, and increased burnout. And then on the whole system of the healthcare delivery, where the biggest casualty is the eroding public trust, increased costs for remediation, defensive medicine practices, higher insurance premiums, and regulatory penalties that affect the entire institutions. So when errors occur, the impact extends far beyond the immediate clinical consequences. Understanding these cascading effects underscores why safety must be a core clinical priority, not just an administrative concern. Safety is not someone else's job. Safe care is the clinical care, and clinicians, especially doctors, must own that responsibility. Many view patient safety as the hospital's responsibility or the quality department's responsibility or something handled by checklists. But doctors are the central decision makers in most care encounters. Their choices guide diagnosis, treatment, handoffs, and follow-ups. Their words influence patients, families, nurses, and administrators alike. If healthcare is a team sport, then doctors are its captains. A true captain doesn't just play their part well, they bring out the best in others, orchestrate collaboration, and take responsibility for the team's performance. The captain's mindset has to be that you have to assume responsibility, take ownership of the outcomes, good and bad, rather than deflecting when the systems fail. You have to facilitate communication, create environments where all team members feel empowered to speak up about safety concerns, including the patients themselves. Value all expertise, recognize that safety depends on the unique knowledge of every team member, from nurses to pharmacists to many other people. And embrace learning. Approach near misses and errors as opportunities for improvement, not failures to hide. So in today's complex health environment, no single professional can safeguard patient safety alone. But the physician must lead the effort, engaging the entire team in a shared mission of safe, effective care. So from the Hippocratic ideal to the daily practice, like I said, that it was Hippocrates 2,500 years that we may remember our oath, first do no harm. Yet in the brush of daily responsibilities, it is easy to lose sight of this foundational principle. Reclaiming patient safety as a core part of clinical identity, not just as a compliance requirement, is the key to the real improvement. So identify, recognize safety risk specifics to your specialty and practice settings. You have to learn, extract meaningful lessons from both successes and failures. We must share by documenting and discussing near misses and errors openly with the colleagues, and implement changes based on insights and measure their impact. This continuous cycle of improvement, transformation, safety from an abstract concept into a tangible daily practice embedded in the clinical work can make a huge difference. So 4 practical approaches that I have thought about for physician-led safety. One is the specialty-specific error documentation. Create and maintain a detailed logs of near misses and adverse events within your specialty. These should be anonymized, peer-reviewed, and regularly revisited, not to assign blame, but to identify patterns and improve outcomes. We at CAHO, we have created a platform in our website where anybody can just document any near miss or an adverse event, and we can go into the root cause analysis. Second is a dedicated safety sessions at the professional conferences. What we see is that in every professional conference, a huge amount of time is being given to their domain knowledge in advancing the science of that specialty. However, I think a session on patient safety and where we talk about the near misses and the adverse events that have happened in that specialty can go a long way. And this will highlight the importance of focusing on the issues of patient safety. So these forums can be educational and therapeutic, changing the culture from shame and silence to shared growth. Cross-specialty learning. Many errors occur at transition points between departments or levels of care. Sharing lessons across specialties help identify blind spots and can spark systemic improvements that benefit the entire care pathways. Modeling safety as ethical leadership. Be open to feedback, encourage reporting of concerns, respond non-punitively to errors, and advocate for systems that support better communication. Ethical leadership means confronting what went wrong and ensuring it doesn't happen again. Excellence is earned through humility. It is tempting, especially in high-pressure environments, to strive for an image of infallibility. But true excellence comes from the willingness to reflect and improve. The journey to healthcare excellence is not about chasing perfection. It is about acknowledging our humanity, recognizing the inherent risks in our work, and building cultures where learning and improvements are embedded into daily practice. Great clinicians are not those who never make mistakes, but those who learn from them and help others to do the same. So the vision for a safety-centered healthcare system will be where every clinician sees themselves as both healer and a safety guardian. safety becomes inseparable from the clinical identity and professional pride. Teamwork members work as partners, not in silos. Doctors, nurses, pharmacists, and administrators align around safety goals. Every decision made with awareness that lives depend on it. Both clinical and interpersonal choices reflect safety consciousness. Humility is strength. Improvement is continuous. Organizations celebrate learning and transparency rather than perfection. We can build this system, and it starts with physician leadership that prioritizes teamwork, communication, and shared responsibility for the patient outcome. So being a safe clinician is the true hallmark of excellence to my mind. So when care is safe, it is not only more effective, it is more compassionate, more trustworthy, and more fulfilling for everyone involved. Being brilliant in clinical knowledge is not enough, and for creating true safe care, leadership is not optional, it is essential. And friends, I bring you greetings from CAHO, and an organization which is going to be your partner in taking this journey to whatever I have said. And it's truly, truly very, very important that we understand that this issue of patient safety has to be made a central point in the delivery of our healthcare. So thank you, Dr. Arun.
Thank you. Thank you, Dr. Vijay. I think it's a very important message for all of us. And especially at the end of your presentation, you did mention about safe clinicians. Well, we always say I'm a clinician, I'm orthopedic surgeon, I'm ENT doctor, I'm general surgeon, I'm cardiologist, but within our heart, we should be able to say I'm a safe cardiologist, right? And when can you claim it ethically? When you really practice all those things which are meant for that. And I agree with you. While practicing, you have to observe yourself, you have to observe the outcome, and anything wrong, documentation, and documentation, not for yourself, but sharing with your colleagues, sharing with the platform. And that ultimately, that big platform will be a learning platform for every one of us. And needless to say, once it is there, the ethical leadership, I appreciate, well, the ethical leadership is the key base of our ethical consideration and perhaps in the best interest of the patient. Thank you very much, Dr. Vijay Agrawal, and I'm sure under your leadership, the organization like CAHO is doing a wonderful job for India as well as for the entire associated countries. Now I would like to proceed further. I've seen we have been joined by Dr. Gyani. Dr. Gyani, can you hear us?
Of course.
Good morning, Dr. Gyani.
Very good morning.
Good. So, in Dr. Vijay Agrawal, in your absence, covered beautifully the clinician's role in patient safety. And Dr. Gyani, everybody knows him, the person who was initially associated with NABS Quality Council. He's supposed to be the quality person of India and is strong advocate of patient safety. Dr. Gyani, we'd like to hear from you your basic fundamentals of patient safety before I proceed to my other clinicians in front of you.
Thank you, Dr. Agrawal, Arun Agrawal, because there are two Agrawal sitting in front of me, and so I have to.
And the
both
third
are,
one is missing.
The third one is missing. Oh yeah, but आप दोनों ही दिग्गज अग्रवाल हैं हमारे और so actually this topic of course is very important and जब NAPH हमने शुरू किया था
जी.
I think basically NABH has done definitely wonderful work because it has established the framework for quality governance. Now, framework actually we keep certifying through accreditation process, but the what Vijay just now spoke, that we needed an organization which actually can take the hospitals beyond and actually can help them to sustain and institutionalize the quality framework. And more importantly was that they take the ownership of the quality themselves rather than depending on once in 3 years or once in 4 year visit by the NABH. So that is a role which CAHO is beautifully playing. Now coming very shortly, because we have got 3-4 more speakers, the patient safety, I always keep saying that medical errors, which even Vijay keeps speaking at all the platforms, I distinctly can say that medical errors happen for few reasons, which I'll just mention in the points. One is the poor communication. It looks very simple, but actually, I missed the initial part of Vijay because he shows the statistics also, that the communication, poor communication is the leading cause of the medical error, surprisingly. And in fact, it is time that we educate our undergraduate students and even the PG students on the importance of the poor communication. That is one. Secondly, let me tell you that currently, because I am dealing more nowadays with the government on the sustainability issues, the inadequate staffing and fatigue is also playing a very important role in the medical errors. Because I'm now giving you little non-clinical aspect, which are very important in ensuring the patient safety. Because of the financial unsustainability, because of the various policies, which we will not discuss at this point of time, we are now looking at that either there's an inadequate staffing, number one, unskilled allied healthcare workers are across the hospital, that is one, overwork, burnout, that are the also causes which are, adding to the medical errors. And the bigger aspect which we are discussing is the patient safety. Third aspect which I would like to say is the incomplete or incorrect patient information. Because of we have very limited time, large number of patients are coming, we most of the time are missing on understanding the historical part of the patient. Allergies, what they are having, or the past test results they are having. So you really need time when we are doing OPD consultation. So I tell you that incomplete or incorrect patient information also is the one of the reason. And of course, the safety culture, that patient safety doesn't come by getting NABH accreditation. Actually, that is where the top leadership, you were also, Arun was also talking about it, the leadership commitment. Now, actually, this has to percolate down through a culture, institutionalizing culture, ownership, these are very difficult things. In fact, in the healthcare, we are really not very familiar with these things, what automobile industry did, what IT industry did. Gradually now we are also getting into it. So establishing the safety culture is another important point. In terms of processes, of course, medication error, we all are aware about it. This is again next to communication. Medication error is the second largest cause of the medical errors, the wrong doses, drug patient, all sorts of things, dispensation is also one of the leading cause. Another thing I will say, the standardized protocols. Standardized aspect of very medical aspect was, let me remember back into my COVID time, we were actually changing the protocol so frequently because it was everything was new at that point of time. And we were finding it difficult to percolate down to forget about tier 1, tier 2 and tier 3 towns. So this standardized protocols is one thing, they keep changing, but the important point is how do we really disseminate them among our junior surgeons, or why junior surgeon, even the senior surgeon and physician. So that is the one, lack of standardizing protocols. Diagnostic error, of course, is another call. We have to focus on that. And infection control, which is the hub of the patient safety, which comes through simple things like hand hygiene or improper sterilization. So these are the things which actually are related to the processes what we follow. And finally, I will say one or two more aspect is that technology and equipment failure. For example, in the CAHO, first time we have brought the biomedical engineers into the forum. Nobody used to bother about them, but now there is a full-fledged forum of biomedical engineers. In fact, I would like to call them clinical engineers now. And the wrong functioning, wrong calibration, poor upkeeps, that also can result into the medical errors. And finally, what Vijay lastly said is that we work in silos, and the time has come. How do we really make hospital function as one single team? It's a very difficult job, not a team of consultants, not a team of junior residents, not a team of nursing staff, not the team of allied healthcare, but all four. How do they come together for the single objective of combating, establishing the quality culture? So, Dr. Arun, this is few points from my side. If later on, if required, I will pitch in.
Thank you, Dr. Gyani. We'll come back to you soon. And of course, thank you for emphasizing for team spirit, teamwork, as well as you very well said that today we are so much into technology that perhaps the expert from technology should be the integral part of us. You can't do without that. And that is what I can see, that what is happening futuristically in medical education also. And if not, it should be undertaken. So now I think I would like to invite my next speaker, Dr. Lalu Joseph. She is the lady from CMC Vellore. Dr. Joseph, let me tell you my feeling. If I want to give maximum respect to any of the medical college, I have been Dean of Maulana Azad, but I give maximum respect to CMC Vellore. The dedication and the simplicity in that campus is so much that I really appreciate it. And Dr. Joseph is, of course, the person who is into administrative part of quality manager, and looking after, and she is very much part of NABH also. Whenever there is such type of activity, Dr. Joseph is always there. Dr. Joseph,
So she is the
would like to share.
of
Yes.
Dharma also, sir. She's
We like to know from you, as an administrator, what are your implementation points? Just now, Vijay said ethical leadership. So what is your message to our leadership, various leaders, a small hospital, big hospital? And since CMC is very well known for ethicality, so that goes without saying. Please.
Thank you. Thank you so much, sir. It's always a pleasure listening to you and being on stage with you, Dr. Arun Agarwal, sir. We have shared several forums together, and it's always that humble, the way you present and the way you bring out the points is what is most amazing. Thank you for appreciating the work of CMC. So let me narrate my experiences and probably what I have seen in good leaders who have actually implemented things in their organization and how things have improved towards patient safety in organizations. The first thing that I would say in any organization, be it small or big, it is the leadership's commitment to quality and patient safety. If the leaders are not involved, the others in the organization will never be involved. So quality, patient safety is not a one-time thing. So if you realize when accreditation exercise happens, we call it the O-Punch then. It is probably those 4 or 5 days that people are running around setting systems in place. Of course, accreditation is the framework. Without that framework, we are not talking about quality or patient safety. Certainly, that framework is established. But year-long, 2 years, 3 years, how do you really maintain that? How do we improve upon that? So that's where the leadership comes into the picture. If the leadership is not committed, the culture never gets established. So for patient safety, the first thing, in my opinion, is to create the culture. So for creating the culture, the leader has to be the captain. So what is culture? When it's one person or the quality manager, patient safety officer is talking about patient safety, it is that person's opinion. When it becomes everybody's opinion or attitude, then there is culture. So culture takes about 10 to 15 years to get established. So accreditation exercise, if it is there in an organization in a good way for about 3 to 4 cycles, then the culture gets established with the leadership. So leadership is the first thing I would say. I just want to bring about the salient feature of a leader towards this culture creation. That person has to be supporting. He need not be in the front in every meeting, in a committee meeting, taking the leadership there. But he or she should commit to taking this journey forward. They should be supportive, at least not detrimental. Some leaders, they just brush aside things and say, oh, okay, this is only for accreditation, not needed. But that cannot happen. That leader certainly has to be committed. So therefore, at least support the activities rather than being detrimental. The second important thing is involving the departmental leaders into this journey. And that's exactly what Dr. Vijay Agarwal keeps talking about, involving the clinical leaders. So the quality exercise or safety exercise is not limited to the quality manager in the organization. It is the departmental leaders, it is the clinicians of the departments who will have to be involved. Is it an easy thing to do? Certainly no. But once they realize the data that comes out from their departments on outcomes, how they are performing, when they start looking at data, benchmarking themselves, benchmarking their procedures, looking at infection control parameters, they certainly fall in line. They get motivated. They start looking at data in a very critical manner, and then they realize, okay, there are problems here which we will need to correct. Standardization is required in a particular protocol, then they'll get involved. I can certainly tell you our experience. When we started with our journey in CMC Vellore, it was not an easy one at all. You look at standardization of protocol, there were n number of protocols and the postgraduates would be moving from one unit to the other. So when we asked the clinical departments to put down the protocols, we've been in existence for over 125 years. We are one of the leading centers. This is typically what any large organization comes out with. So we realized that there was a need for standardization of protocols. This I'm talking about in 2009. So we took the senior leadership of 14 broad specialties and higher specialty to an area and asked them to put down the protocol to transfer a patient from emergency department to priority 1 emergency patient to ICU. 14 people gave 15 protocols. So when you tell them these are the postgraduates looking at consultant-specific protocols, unit-specific protocols, there are errors bound to happen. When we were able to demonstrate, they were able to come together and put down the protocols together. And today we have what is known as Clinicians General Guidelines booklet, which has the protocols starting from admission to discharge to surgical site marking. So what do you do for surgical safety, for any safety? So that has become like the Bible in CMC Vellore for postgraduates and interns to be taught when they come into the portals of our organization. So that standardization took about 10 years, I would say. Despite challenges, we went ahead with standardization of protocols because we didn't want to put the young ones at risk. So therefore, involving the clinicians, it's a very difficult one, but not certainly it's not something that you cannot achieve. So as they get involved, they realize the importance of it. We have a mandatory clinical audit for all our interns, medical interns, the CRRI. So without doing the clinical audit, there's no clearance given to them. So each medical intern does a clinical audit, a very simple one. Why are we doing this? Because we want to catch them young. And these are the people who are going to lead their departments in about 5 to 10 years. So when they get into understanding data, how you can work with data, how you can make improvements with data, then it's a big change that comes in. So if the leadership of the organization is not involved, this is just not possible. Slowly getting the clinical teams involved. So the second thing is to get the clinicians and the leadership involved. The third important thing is teamwork. So as a leader, we have to inculcate teamwork in our organization. So it is not just the doctors. It is not just the nurses. I came from a different industry. I'm an engineer by background. Have worked in several other areas before I landed in healthcare. Today, it's become, it's that passion, certainly, with which I'm working in healthcare. So when I came into the healthcare, I realized that every group is a silo by itself. Nurses don't want to hear instructions. Doctors are a separate silo. Unit 1, Unit 2, Unit 3 functions separately. Little kingdoms all over the place. Nobody even knew the clinical engineers or the CSSD, what they do. So without getting everybody together, physiotherapists, technologists, so this is the most complex industry, and people don't talk to each other. So teamwork is so totally lacking. So how do you bring everybody together? That certainly is the role of the leader. So when there is an event, it is not just the clinicians and the nurses, it is the entire ecosystem. And that is where quality accreditation in our country has certainly played a huge role. And that's exactly where CAHO has played a leading role of bringing professionals together. So as the Secretary General of CAHO today, I can tell you, we have forums for rehab professionals. We have forums for clinical nursing, for biomedical engineers, maintenance engineers. We've got forums for clinical dietetics professionals, and you name it, technology, IT professionals. Why have we done this? To bring them all together to talk about patient safety. Even housekeeping professionals are so important for patient safety. So in an organization, when CAHO looks at it at a macro level, in our hospitals, we have to look at it at a micro level of bringing everybody together. And that's the role of the leader. If you are able to bring departments together, talk about patient safety end to end. So that's the third thing. And the fourth important thing, and the most important thing, is communication. When anything happens, the leader should be there in the front to communicate to the team, this is what should be done. When our concerns were very minimum, when we did our first audit, it was just about 57% of the patients who had consent for surgery. And when we presented this, people didn't understand, our clinical leaders. No, we write it here, we take it like this. This was way back in 2010. And our leaders stood in the front and said only one thing: no patient will be wheeled into theatre without consent for surgery. And the holding bay nurses are empowered to move the patient back. Ruckus for about 2-3 days. End of third day, 99% of the patients had consented for surgery. So some of these things, the leader should be bold enough to communicate what is needed. And the most important thing is the leader in the front. And for lack of time, I'm just going to summarize and bring about one important point. End of the day, it's all about ethics, ethics and ethics. If the leader on top is not, trying to bring that in the forefront, transparency, accountability when it comes to patient safety, going through incident in a fair and blame-free manner, making sure that the team is together and everything is done in an ethical manner, nothing can be done. So I always allude to what the father of healthcare quality, Avadis Donabedian, said. Systems and designs are important, but they are only enabling factors. It is the ethical dimension of individuals that is essential for the success of healthcare. It is the love for the profession, it is the love for God, and it is the love for the patients that you have. If you have all that, you can work backwards and try and correct the system. And I think we have that in plenty in our country. And organizations like CAHO in the forefront with lot of love for the patients, the professionals, and the overall industry has come together to bring everybody together to talk about patient safety. And it is with that love, it is time for us to work backwards to correct and improve the patient safety in our country so that our country becomes the champion towards patient safety. Thank you so much for this opportunity.
Thank you, Dr. Joseph. I think very importantly, as mentioned earlier, also ethical leadership. And I mean, Vijay, I feel that India is becoming champion for this particular aspect of patient safety.
Very true, sir.
Because somehow we are dealing with the maximum numbers. It's a game of numbers, experience. We have such a big population to deal with. And obviously, when we are dealing with bigger population, bigger number, our experience has to be richer, right? And one day I'll pray that the time will come when we are called as no default, cockpit approach, nothing. But I know in medical science, there is nothing like zero, but we have to minimize it. So I would like to proceed. My thanks to you, Dr. Joseph, again, and then I would like to proceed with my another very close colleague, friend, Dr. Amitabh Banerjee, who is Professor Emeritus from T.Y. Patil, Pune, and he is the public health expert. And you will hear from him, you will read him many times at different platforms. Dr. Amitabh, what do you think that since we have started talking about patient safety, so in what way we can create an impact in the youngest possible age of a student, right from undergraduate and postgraduate, if they are aware of all these steps, perhaps they will become a safest clinician. What is your opinion about it?
Thank you, sir. I would try to talk something about some system failures. I mean, the young generation should know, like medicine was an art to start with, and the greatest practitioner of the art was the general practitioner. A family physician, he used to, one doctor used to see many patients. And today it is just the opposite, specialization and super specialization. Of course, it is very essential because of the complexity and technological advances. Medicine is becoming very complex. So from the art of medicine, the present day is the art of managing complexity. The art of managing complexity is perhaps getting humanly impossible because of the super specialization and hyper super, and many interfaces have come, like medical equipments, bioengineering, and rightly now we have got clinical bioengineers. As Dr. Gyani said, then as Dr. Agarwal said that the treating team is the captain is the doctor. Here, one thing is, it is almost becoming like managing a large airport. There are many captains, many aeroplanes, many flights. And here, similarly, now we have got many treating teams. Now, elderly population have got multiple comorbidities, and one patient is managed by many teams. And as rightly brought out, most of them are working in silos. So, in their own domain, they may be trying to see that there are no errors, they may be checklist, but what one thing is missing, if we take another analogy from the aeronautical engineering or flights, there some ATC is missing, like we have got air traffic controller. So there is no one general practitioner like the system in the UK. They have got an NHS. All the patients are routed through the general practitioners to the specialist and super specialist, and they come back to the general practitioners. Because I have seen personally, one patient has been getting prescriptions from number of 3-4 super specialists, and there is maybe some drug interaction which is overlooked because one specialist doesn't know what the other specialist has prescribed because there is no time. So if there is a general practitioner, the status of the general practitioners has gone down very much, and no young graduate or undergraduate, nobody wants to become a general practitioner because there is no status. So it is looked down. Everybody wants to become a specialist. They want to become pilots. So we require some ground staff also who is a general practitioner. And if we have good general practitioners, that can come up as a specialty. That's something jack of all trades. So they can coordinate the treatment across various specialties, and they can act something akin to air traffic controllers. Actually, this is just loud thinking. I am just not crystallized my ideas. This is just loud thinking when I see the complexity which is increasing due to technological advances, just like flight control. But we should have a good air traffic controllers at the ground level who can work, who can be a communicator to the patient and to the specialist, some sort of an intermediary, because specialists do not have time and they do not have time to interact with the other colleagues who are treating the same patient. So if there is a common denominator in the form of a general practitioner whose status should be as high as that of a specialist or super specialist, because he or she is managing across disciplines. So if something can come up on those lines, that who are good communicators, may not be exactly maybe a counselor, maybe a doctor, who can work across specialties and communicate to the patient. I think that is something, which came to my mind.
Thank you. Thank you, Dr. Amita. It's a very important aspect, that is the entire channel of looking into the patient. A referral system, who will see first, who will see second, and when should they be referred to the super specialized persons. Yes, I know that is a system failure in our country. And I'm sure organizations like CAHO or ASPI and NABH, and perhaps with their efforts, some sort of step will be taken so that I agree with you, Dr. Amitabh, that patient is loaded with the prescription from different ABC super specialized doctors without knowing the fact that which are the drugs which are interacting and perhaps bringing the side effect. This is a very important aspect which I feel Dr. Gyani and Dr. Vijay and Dr. Joseph and my other colleagues should keep in mind how to perhaps overcome it. So after listening to my expert, of course, my fifth expert panelist, Dr. Vinay Agarwal, is not able to join us because of his illness. And so I'll come. Tiwari ji, can I ask one or two small questions for my expert? Tiwari ji?
Yes, sir, I have question.
नहीं नहीं,
Should I deduct?
आप तो पूछेंगे ही, उससे पहले
Yeah.
मैं एक दो क्वेश्चन पूछ सकता हूँ.
You go ahead, please.
Thank you. Dr. Vijay, as I was talking to, the way you are trying to include each and every pillar of the medical care. And that National Commission of Allied Health Professionals has come. And do you think this concept has to be floated among each and every student, not only among doctors, all the courses of allied health group, of course, nursing, pharmaceutical, already having their basic councils, and now the new National Commission for Allied Health Professionals, and what sort of efforts will be undertaken by CAHO? And I am going to ask the same question from Dr. Gyani also.
Sir, I think, the regulatory bodies do naturally a good job in trying to streamline or trying to bring about a change what is needed in the healthcare delivery ecosystem, and be it the National Medical Commission or the allied health professionals. The problem is somewhere that the impact that should reach the ground level somehow does not happen, or does not happen with that kind of a emergency as is needed today. And I feel that somewhere a more intense interaction between these regulatory bodies and the end users and the organizations such as ours who are dealing with the end users is required.
Yes.
So that the changes which are being brought about are pragmatic and can be implemented in a much more emergent manner. The changes that are now needed because of the emergence of AI and digitization are very, very, very huge. It is surprising that the government had come out with the Ayushman Bharat digital mission with so many years back. They came out with fantastic ideas of the data of the patients being interoperable and so on and so forth. But the use cases of how that is to be used, and nothing is moving forward. I feel at one time in the West, they have spent a lot of time in digitizing their healthcare system, but they were also fragmented. Today, with the emergence of AI, I think India has a unique position to leapfrog, I will say, bypassing that entire need of digitization. We have been laggard, but I think with this AI, we need to kind of get ahead in all fields, clinical and paraclinical, and all those people, and these regulatory bodies need to realign themselves with these changing concepts. The need for a graduate to understand soft skills, to understand communication, to understand finance, to understand humanity is much more important than understanding the clinical aspects, which he's learning from everywhere else. That's my
I agree that all the soft skills you mentioned just now are directly and indirectly related with the entire approach and ultimately patient confidence, patient outcome, and it's an overall approach we have to think. Dr. Gyani, your comment on it? डॉक्टर ज्ञानी
muted.
ठीक है. So the question is about the regulation, is it?
मतलब regulation in the sense how we want to create an system where people automatically get involved into it.
I agree. You see, the point is, this is an old theory that quality, particularly in the healthcare, has to be brought out, and there are three routes. The first route, most important one, is by regulation, because healthcare impacts well-being of the society. So government is duty-bound to bring regulation. So there's nothing against that. But unfortunately, we have not understood one simple point. In 2011, when we brought out the Clinical Establishment Act, I think it was made so complex, the kind of standards and the categories which were brought in. Even till today, hardly 7 states have formally implemented, but even there it is not effective. So about 1 week back, I was having discussion with Dr. Vinod Paul on this very issue, that how we can reduce the burden of compliances. So I mentioned to him that imagine, let us say, Delhi. In Delhi, we have, in the Department of Health, there are 7 officials sitting. And how they can be controlling, regulating 1,800 or 1,700 hospital and nursing homes within Delhi. It is humanly not possible. So I gave him the example that like passport used to be the most difficult job for the society or the population. It was outsourced to Tata, TCS, and today you see it is the most simplest thing. So I think I can just say a simple point, which I told him, that time has come First, you reduce the compliances, bring it to the minimum. Number two, bring it in 2 or 3 groups so that one group can be implemented through one outsource agency, another category can be implemented through another outsource agency. And there are agencies available, for example, conformity assessment body through Quality Council of India, or for the matter, let us say Kaho can do something, certain thing, other can do it, certain, that means you have to outsource and government only do the oversight. So that is the only way you can have effective regulation, because regulation, again and again I am saying, is the most important point, because a regulation means minimum level of quality and patient safety is to ensure. Second is, of course, by the payers, which we are doing it, that the payers can insist upon the healthcare that before we impanel you, you must demonstrate this. Again, who will verify the demonstration? Again, the even insurance company have to outsource. And third, of course, is a time will come, maybe after 10 years, that the public themselves will become empowered and they can choose, they can demand quality and patient safety. And that will come when the hospitals will putting their indicators on the public domain. So that I think I'm just saying it may take 10 years from now. So these are the 3 ways by which a regulation or the quality can be ensured.
Thank you, Dr. Gyani. Dr. Joseph?
Yeah, I completely agree with
How do you see India as the leader of patient safety movement?
Yeah, the way we are going, certainly, Arun sir, as you rightly said, we are going to be the leaders. Because what we do in our country is with that commitment. If we take up something, it's always with that commitment. Otherwise, we don't. Now, today I see most organizations talking about patient safety in a very, very big way. So, one important thing again is for us to really not lose focus. So, upskilling of our current professionals is the need of the hour, because we have professionals at all levels, young ones, the ones who have been in the system for 20 years, the ones who are going to be retiring and continuing to practice as well. So upskilling to the current norms, upskilling to the current retirement, skill-based training, all that is very, very crucial if we have to champion the cause of patient safety. And we also need to really get into training our young ones in a big way in medical colleges, in nursing schools, in allied health sciences, and the professionals who are coming into healthcare as well. So if we focus on really training, continuous learning and upskilling, I'm sure we will be leading. And there are several organizations today committed to the cause. I can, bring out that when we started Kaho, when I joined in 2015 and Dr. Agarwal joined in 2013, today from an organization, it has become a movement. We certainly see the growth of the involvement of professionals across the country towards this journey of patient safety, because they see the need for making this a movement. So today, the people have all come together, they have joined hands, but it is for all of us to encourage this movement to make it as a global movement as well. So I have no doubts in my mind, in the next 10 years or next 7, 8 years, India will be in the map leading patient safety. Thank you.
Dr. Amitav,
That's
short question to you.
yes, sir.
As Dr. Joseph said, it's a movement. In what way public health expert can join this movement? And perhaps, when we talk about public health, that public health expert deals with not one, he or she deals with thousands and lakhs.
Thank you, sir. Actually, the big hospitals, the big cities, the corporate hospitals, they will achieve it, sir. Because now medical tourism is a big industry. The target audience is the world. But my concern is the public hospital.
But patient safety is for everybody.
Yeah. So my concern
it should be there in a village also.
Yeah. So that is my problem. So that is the dark area, the dark underbelly of healthcare in India, that we attract the best from all over the world. We have the best doctors in large cities. But according to the latest Comptroller Auditor General report also, 30 to 40 to 50% staff in public hospitals across the country, including paramedical staff, nurses, equipments, are in disuse, they are deficient. Either the staff is there, equipment is not there, or the equipment is there, the staff is not there. Doctors are in short supply from district level downwards. So we have to fill up the vacancies, sir, and that is, as I said, young medical graduates should be given incentives to serve across the country, not only in big cities. So that is my concern as a public health specialist.
Thank you. So that brings the end of discussion from my side. Tiwari Sahab, your
Yes, sir.
experts are there in front of you, and I'm sure
Yeah.
there will be questions. Please go ahead with your questions to any of
Thank you,
them.
sir. Thank you, sir, very much. Sir, I have listed some of the questions from all the corners. Now, I would like request to Dr. Vijay Agarwal. Sir, this question goes to you. Sir, am I audible to you?
Yes, sir. Yes.
Yes, Tiwari ji.
So, this question raised from Ramesh Sharma from Bangalore is willing to know what are the most common preventable errors in hospitals, either in rural or private or government, and how can healthcare team address them effectively?
Well, I think some of that has already been enumerated in the sense that, for example, we know that medication errors are one of the biggest of the problems that we see in the hospitals. So, and if you just want to, let's say, attack this problem of medication errors, one of the biggest contributor of that is the great handwriting of our doctors. And in spite of even the accreditation insisting on that the doctors need to write either in capital letters or it has to be a computer-generated prescription. At least I still see a lot of prescriptions which are handwritten. And please understand the problem of it is that what does the chemist read? What does the other nurses are reading? So there are going to be transcription errors. We have problems of reconciliation of medicine. The patient comes with a certain medicines when he comes out of goes to the hospital. When he comes out, there are a different set of medications. Nobody is explaining to him. Nobody is explaining as to the reasons of. So on the other hand, we are trying to empower patients also to say that he has to spend time in understanding his prescription and many things. So that is one big area. The second area that, like in some way, Dr. Amitabh Banerjee talked about, and that is that there is no air traffic controller. So especially, I will say, in a field like ICU, where same patient is being subjected to a nephrologist, a gastroenterologist, and a cardiologist. So sometimes the primary physician who should be the one person in charge is somewhere lacking his responsibility to monitor and to take the whole treatment forward. So that kind of I'll say creates a huge amount of problem. So this is a topic, Tiwari ji, that we can go on, and I'm sure that we can address Ramesh ji at this thing. But just to tell you that on every possible way, right from a delayed diagnosis to a wrong prescription to a wrongly doing even a surgery on the wrong side, there are huge number of examples that we can keep encountering which need to be eliminated, which need to be.
Thank you, sir. Next question goes to Dr. Girdhar Gyani Shah. Sir, am I audible to you, sir? Dr. Gyani Shah?
Yes.
Sir, this question goes to you. Sir, could you tell us how can smaller clinics with limited budgets implement a strong patient safety protocols without compromising quality?
I think this is the biggest issue today, which is bothering all of us. You know, government keeps saying, everybody rather keeps saying that healthcare has to be affordable. Now, affordable means what exactly? You know, the healthcare delivery, like any other delivery, whether it is a legal service, education service, it is going to cost. Now, that cost has never been quantified till today. Now, most of government today are very aggressive in pushing what they call is through Ayushman Bharat or through any other scheme. And they are claiming that India is 70% population of India is being covered through Ayushman Bharat or other central government schemes. Now, in this process, the government doesn't have the adequate number of beds. So they buy the healthcare from the private sector. Once you are buying from the private sector, obviously you have to pay for it. And because government doesn't have that kind of budget, the kind of costing which has been done is below par. Now, because of that, the healthcare services, patient safety, if you really ask me, one of the biggest culprit is this affordability. Affordability means lack of budgetary support. With less than 2% of GDP being spent by the government, we cannot afford, rather cannot have that kind of safe healthcare services in our country. So I think sooner or later, this has to be addressed. And unless we do that, the quality will take the back seat.
Thank you very much, sir. Next question goes to Dr. Amitabh Banerjee, sir. Sir, could you tell us, in case of unavoidable medical complication, how should communication with the patient and family be handled to maintain trust? Please.
This is most important, sir. There have been studies that if the patient is transparent, there has to be transparency. The complications are there, the prognosis are there, and there have been studies when the doctor has communicated, and also in case of an error, instead of trying to hide it, good communication, and patient is also part of the treatment decision. There are less litigation, there are less here. So communication is important in particularly serious case. If time is taken out to talk to the relatives, talk to the patient's relatives, because the patient may be very serious. So there are less chances of litigation, and there are less chances of violence against doctors. They have done studies and they have found out that patients do not litigate doctors. Patient do not litigate the medical errors. Patient litigate the doctors. There have been cases where one doctor has made an error that radiologist failed to detect an early tumor, and the patient sued the surgeon. And when asked, it wasn't the fault of the radiologist, the patient says, no, the surgeon was very well behaved. He explained to me, the radiologist was rude to me. So these are some of the things which has come up. And if there are too many lack of communication, doctors go into defensive. I mean, if there are too many litigations, too many violence, doctors go into defensive, and sometimes it harms the patient as well as the profession. There have been earlier cases. There are sometimes, as a serious patient, as you said, with complications, there may be certain measures which may be taken, I mean, calculated risk. There is a risk, but it's a calculated risk. And if there are too much of distrust between patient and doctor, no doctor today is ready to take a calculated risk. I have personal experience. I have started my career as an anesthesiologist, and after some time I switched over to public health. But serving in remote areas in small hospitals, a couple of times I did replace, when the anesthetist was not there, I did replace the anesthetist even after 10 years of gap or 20 years of gap, and I could save the patient. But today I wouldn't do it again, because nowadays the distrust is so much. If something goes wrong, I could save the patient, and today I would not tell anyone in my position to do it, because if something goes wrong, there are a lot of documentation, lot of cases that you are not supposed to do it. You are out of practice. You are no longer anesthetist. In fact, once I was the anesthetist, and it was a gynec's place. They were bleeding. The patient was bleeding heavily, and it was a service officer's wife who was a radiologist, and there was no gynecologist or surgeon in that remote hospital. So she did the surgery. I did the anesthesia, because she had done house job in gynecology some years back. She said she can do it. So we could save a patient, but today such patients will not be saved, because there is so much of distrust. There is no between patient and doctor. So once, if you can involve the patient and there is a good communication, many of the problems can be solved.
Thank you, sir. Very much. Thank you, sir. Now, next question go to Lalu Joseph, ma'am. Am I audible, ma'am?
Yes, sir. Yes, sir. Please.
As a quality measure, and I heard a lot about you from Dr. Vijay Agarwal's mouth. Could you tell, ma'am, what are the key indicators that hospital administrators should monitor to measure patient safety performance?
Yeah, there are several key indicators, particularly clinical indicators. And I think one of the most important would be infection control related indicators. When it comes to real-time hand hygiene practices in the hospitals, what is the compliance to that? When it comes to bundle care in the hospitals, or whether it is VAP, the catheter-associated infections, or central line or surgical site infections, I think those are the most important ones, in my opinion, the infection control related indicators. Otherwise, it is certainly the department specific clinical indicators. Most hospital leaders tend to look at finance related indicators or the number of patients who are coming in, the footfalls. Those are very, very important. But only if infection is prevented in the hospital and the clinical outcomes are good, that the patients would be coming into the system. This is particularly for private hospitals. So I think any hospital administrator, leader, owner should have a pulse on the clinical indicators, particularly the infection related indicators and safety indicators that amounts to incidents that are happening, the kind of complaints that are coming from patients. These are very crucial. Thank you.
Thank you very much. My last
Tiwari
question goes to Dr. Arun Agrawal Sahab. Sir, could you tell us, this is a very important question for you and you can easily answer this. Sir, could you tell us how do international patient safety standards differ from Indian standards and what can we learn from them?
देखिए तिवारी जी, इंटरनेशनल स्टैंडर्ड वर्सेस इंडियन स्टैंडर्ड्स। इंटरनेशनल स्टैंडर्ड में जब हम बात करते हैं तो उनका स्टैंडर्ड एक अपने एक्सपीरियंस के साथ है, जो कुछ बड़ी कंट्रीज भी हैं, कुछ छोटी छोटी कंट्रीज हैं। कभी कभी तो लगता है कि हमारा एक शहर जो है वो पूरी कंट्री है बाहर है। तो उनके एक्सपीरियंस से तो उनका सिस्टम थोड़ा डिफरेंट है, और वही चीज मैं अभी मेंशन भी कर रहा था और शायद अपने एंड सेंटेंस में वही कहने वाला था कि उन लोगों ने अपना स्टैंडर्ड जो डॉक्यूमेंटेशन पार्ट जो हम कह रहे हैं, वो डॉक्यूमेंटेशन पार्ट उनका हमसे बहुत अच्छा रहा है। इसीलिए वो लोग कुछ अपने स्टैंडर्ड्स को, एक्सपीरियंस को गाइडलाइन के तौर पे हमसे पहले लेके आए हैं। बट नाउ वी आर यूनाइटेड, नाउ वी आर टुगेदर and we want to give it back to the world. So that is why I was mentioning that our experiences to be laid down in terms of some sort of guidelines, etc., will become the most experienced guidelines. ये सब चीजों के लिए हमको नंबर चाहिए और नंबर्स हमारे पास हैं। अनफॉर्चुनेटली ये नंबर नहीं होने चाहिए, लेकिन हैं। इसलिए वी वांट all our colleagues, all organizations to get together and perhaps come out with the most experienced guidelines for the entire globe. That is what I wish, that we will definitely, we are doing it. If I try to recollect, Vijay, at least from my side, we started talking about patient safety in early 2000s, but in 2 decades, we have really progressed. You go to any hospital, the administrators, the clinicians are talking, thinking about it, but of course, a lot to be done. So I'm hoping that we will become global leaders.
Thank you very much, sir. Now,
Can I just add a word?
Yes,
that
yes.
I feel that every time, please don't consider that the international standards are better than our standards.
That
They
is
may
why I
not
said-
be even applicable to us. And please understand that even after 100 years of their accreditation systems, Today, 250,000 Americans are dying because of the preventable medical errors. So they have their own problems. We have our own problems. But like Dr. Arun said, that I think most important is the data. They have a data at least that is showing that whole thing, that where are they? We keep sweeping things under the carpet. I feel that definitely a lot of our systems are far better than their system. There is a huge way that everybody can learn from each other. We need to learn from whatever is good anywhere else going on, but does not mean that let's not try to always look up to the international standards. That's what I think.
I fully agree.
Thank you very much. Now, sir, kindly conclude this today webinar.
So, thank you very much. Thanks to all my experts, Dr. Vijay Agrawal, Dr. Gyani, Dr. Joseph, Dr. Amitabh. They all talked about various aspects of patient safety, which is ultimately for whom this is. The patient safety is for a person who has come to us with faith, with confidence. They have come to Dr. Vijay Agrawal that he will give his best to look after my interests. And one thing is always hammering my mind, Vijay, we are trying to improve ourselves. We are perhaps on the path of that. Dr. Gyaniji, what will we do for all those factors which are beyond our control? The poor quality of medicine, right? The poor quality of instrumentation. Poor quality of training. At least in MBBS, we are good. But what happens to our allied health groups? So who will control that? I'm worried about it. As a senior veteran of medical education, I'm worried about that. And here I will stop myself. Again, thanking all of you, and my final thank to team of Tiwari ji. They really do hard work. If you go through the magazines, it's very well written. All the content is wonderful. Please, Tiwari ji, continue your efforts, and it will create a lot of impact, not only for medical professionals, but for all the stakeholders of healthcare. Thank you.
Thank you very much, sir. Thank you very much to all of you. Thank you very much.
Thank you, Vijay, Dr. Joseph, Dr. Gyani,
Thank you, sir. Thank you.
Amitabh
Thank
ji,
you. Thank you.
an entire team of Mr. Amrish Tiwari.